So, in my talk this evening, I was going to cover superb microvascular imaging, which is state-of-the-art Doppler technology, really speak about the emerging diagnostic applications of contrast-enhanced ultrasound, how fusion can be used to help us in diagnosis, and really what is a bit of hot topic today is elastography, particularly shear wave elastography in liver assessment. So, superb microvascular imaging, or SMI, is really state-of-the-art ultra-fast Doppler technique, which is unique to Toshiba Medical Systems, and it improves the sensitivity and resolution of the slow-flowing microvasculature. How does it work? Well, in conventional Doppler filters, what happens when they try to remove clutter is it also removes some of the signal that you get from the slower flowing vessels. And SMI is really quite a unique algorithm which manages to just remove the clutter but preserve the microvessel flow. So what you'll see in some of the images I'm going to show you are that you actually get better definition and resolution of vessels you probably wouldn't see with standard power or color Doppler. And of course, it is done by using high frame rates, but you do have a little bit of a motion artifact to deal with, and again, I'll allude to in my presentation a bit later. It comes in two forms, either the monochrome SMI or color SMI. I favor the monochrome SMI only because it is slightly more sensitive. It has a twin view, and as I'll demonstrate later, the cursor is very useful in this mode. So here's an example of a pathological lymph node. It's enlarged, it's lost its echogenic hilum, and when you turn on power Doppler, you can actually see some abnormal vessel flow. This is ADF, but what happens when you turn on SMI? Here it is. This is the monochrome version. You have your B mode, and this is just the microvessel flow around it. And you can actually appreciate now the abnormal surrounding vessels around it, which you really couldn't see with color or power Doppler. And this is the color form which you have overlaid over the B mode image. So this, a little bit more sensitive, great detail of small vessels which we weren't able to see before. You can actually see these vessels down to very, very minute sizes. And I only use this as an example because this is a 3mm cancer within a testes. If you turn on power Doppler, this vascular lesion, you lose it. But you can actually see these vessels much more clearly with SMI. You may say, where is it? But in using the dual cursor, you can actually see exactly where the lesion is compared to where the vessels are. So very helpful cursor when you're using the monochrome version of SMI. Here's just another example of how good it is at looking at inflammation. This is a sebaceous cyst, perhaps some subcutaneous edema in the soft tissues. But when you turn on SMI, what you don't appreciate is actually how vascular the soft tissues are, and this is really an infected sebaceous cyst. And it is this picking up of these inflammation which we found very useful, particularly at assessing tendons and joints. Here is an example of a patient with rheumatoid arthritis and a very sore talonavicular joint. You can see there is synovial hypertrophy. When you turn on power Doppler, you can see actually quite a lot of flow in it, suggesting an active synovitis. Switching to SMI, you can actually see the much smaller vessels diving deep into the joint itself. So you get a better resolution of these small vessels in patients with active synovitis. Here's another patient with rheumatoid arthritis, and we're at the wrist joint now, and you can see a synovial hypertrophy and some irregularity to the bone. When you turn on power Doppler, again, it is hot. Some blood flow flowing in there, but perhaps you get a better appreciation of exactly how much vascularity there is within the synovium when you turn on SMI. You can see these small microvessels and neovascularity around the whole carpus that we weren't able to appreciate before. Here's just an example of another radiocarpal joint synovitis, this time with the color version and then the monochrome version. You can see you get a bit more detail with the monochrome version itself. Well, you can say, well, so what? You can actually pick up the vascularity with power Doppler anyway. But how about the subtle low-grade inflammation which you don't see with power Doppler? And I'm going to show you some examples. Here is a patient who turned up with a tender knee at the distal patellar tendon insertion near its tibia. On B mode, you don't really see very much at all. When you turn on power, really not very much vascularity in the area of tenderness. He had come for a steroid injection, and it was very difficult to know where to inject. But when you turn on SMI, you can actually see the increased vascularity in the tendon itself, which you weren't able to appreciate with power Doppler. And this is exactly where he was tender. So it changed his management. I gave him a steroid injection, and he was much better with it. Here's another example of a patient with rheumatoid arthritis and pain in the sternoclavicular joint. You can already see on B mode, there is synovial hypertrophy. When you turn on power Doppler, and these are noisy images because we had turned up the gain to get as much signal as we couldn't actually pick up any flow within the joint itself, maybe around it, but not very convincing within it. So was it active synovitis? Well, when you turn on SMI, you can actually see these abnormal blood vessels flowing into the joint itself. So here we are picking up really slow-flowing microvessels in inflammation which we weren't able to diagnose previously. Another example, slightly smaller joint now, in the carpometacarpal joint of the thumb, synovial hypertrophy, and you can see on power Doppler, really very little signal within this area of inflammation. So perhaps you might think it's quiescent, but the patient has tenderness. But when you turn on SMI, you can actually see these microvessels and abnormal vascularity within the joint itself, denoting an active synovitis. It's also shown in small joints. So this is just the metacarpal phalangeal joint. We're getting smaller and smaller to the smaller joints here. And you can actually see really no significant synovial hypertrophy, but in this patient with rheumatoid arthritis, there was pain. Not very much signal with power Doppler, maybe on the surface of that. But when you turn on SMI, you actually then begin to appreciate these small vessels within this area of inflammation itself. So here we are picking up really low-grade inflammation, which we weren't able to with power Doppler. Another example, patient with a lateral epicondylitis or tennis elbow. You can see there is some tendinopathy of the tendon itself, really not much signal on power Doppler itself, but when you turn on SMI at this tendon insertion or origin here, you can actually see active vascularity denoting an active synovitis. So this led us to conduct a little study at comparing SMI versus power Doppler at detecting low-grade inflammation in joints and tendons. We recruited patients presenting for an MSK ultrasound at Charing Cross Hospital over a one-year period, and we included them if they had any one of the following changes, either abnormality on B mode image, signal on power Doppler, or signal on SMI. I collected the clips myself using the 80 megahertz probe on the Apleo 500, and they were stored and assessed later by 3 MSK radiologists with more than 10 years of ultrasound experience. They were asked to score if vascularity was seen in the joints or tendons with power Doppler, SMI, or both. And if they saw signal on power Doppler and SMI, they were asked to score on a visual analog scale based on sensitivity and spatial resolution, whether one or the other was better, no better, mildly better, moderately better, markedly better. And we also documented a change in patients' management, i.e. whether they changed the medication or they received a steroid injection or some extra physiotherapy. To date, we've analyzed 77 patients with a mean age of 44 years and a slight female predominance, but in all, a total of 116 tendons and joints, slightly more joints than tendons. And here is really the key table. What we have here is signal with SMI or no signal and comparing it to power Doppler signal in 116 joints or tendons. Well, in 58, when you tendons or joints, we actually saw power Doppler on both, signal on both power Doppler on SMI, but in 40 of them, we actually picked up flow only with SMI and not with power Doppler, and this was statistically significant. And one other key thing is that in no case did we actually find flow on power Doppler, but not with SMI. So what happens if you saw vascularity on both PD and SMI? Then in about 18 cases, it was no better, but in the majority, there was a tendency for the readers to score it as moderately or markedly better. So from this study, we can show that really SMI allows detection of low-grade inflammation of joints and tendons, which we couldn't see previously with power Doppler, and importantly, without the need for administering contrast agents or microbubbles. And this has significant impact, particularly in the early detection and treatment of patients with the arthritides with disease-modifying agents, and perhaps could give an indication of prognosis and prediction of relapse in these patients, although this would require further studies. Currently, in the rheumatology world, in Europe, power Doppler is seen as the gold standard to denote active synovitis. So this is really quite a game changer. Turning over now to SMI and other potential applications, perhaps in the abdomen. Here's several examples in a patient with a fatty liver. You can actually see a hypoechoic area, and it looks geographical, could be an area of focal fat, and what you like to see is perhaps some vessels flowing through this area to be absolutely sure. This patient was being assessed for metastases. When you turn on color or power Doppler, really there was no flow in this area, but when you turned on SMI, you could actually see some small flowing vessels running through this area itself, and they were not being distorted. So we were even more confident that this was focal fatty sparing, and we didn't need to give microbubbles to confirm that. Here's another example in a patient with liver cirrhosis with ascites and an irregular liver edge and a mass. On power Doppler, it's a vascular mass, so it's really an HCC until proven otherwise. But what we don't see with power Doppler is this basket weave pattern that is described with HCCs. You can see beautiful, exquisite vascular pattern of an HCC. And this is without giving contrast. So we obviously gave contrast to be absolutely sure that this was a hypervascular lesion, and this is the contrast mode, and this is your localizer B mode. The cursor is on where the lesion is itself. The timer is down here, and you see we're at 19 seconds. And you can see it's a hypervascular arterial phase, basket weave pattern, which you actually appreciate better with SMI, but it enhances avidly in the arterial phase and demonstrates some washout. So this was an HCC. Perhaps where it might give you confidence if you didn't use contrast, in this patient with an incidental finding of a hypoechoic area, you really didn't see much with power Doppler, but when you turned on SMI, you can get an impression of what looks like a spoke wheel appearance of the blood vessels flowing through it. So running through everyone's mind, this would be focal nodular hyperplasia. But of course, we give contrast just to be absolutely sure. Again, the contrast mode image itself, and this is the B mode localizer. Here, what we would expect to see with focal nodular hyperplasia, feeding vessel in a spoke wheel pattern, organized enhancement with no washout in the delayed phase. So here you go, feeding vessel, there's the lesion filling from the center outwards, confirms focal nodular hyperplasia, doesn't need any further imaging in terms of CT or MRI scan. How about turning down to renal lesions, where really the enhancement pattern isn't so important, it's whether the lesion is vascular or not. Here's a solid renal lesion which we saw, And when we turn on power Doppler, there really was no signal within it. So is this a complex cyst? Is it a solid? If it's vascular, it's an RCC until proven otherwise. Well, when we turned on SMI, you could actually see blood flow in it, very vascular lesion. So really, something picking up the flow that you couldn't with power Doppler. Again, we of course administered ultrasound contrast, and this confirmed that this is a vascular lesion, area of necrosis. That's the rest of the kidney enhancing, and this is an RCC. Contrast this to a relatively solid appearing lesion, again with perhaps some calcification surrounding it. Is this just a complex cyst, or is this a vascular lesion? Well, when we turned on SMI, we didn't get much flow at all, but you can actually see the nice flow of the normal vessels within the kidney itself. So perhaps this is just a complex cyst or a benign lesion. And when we administered contrast, there you go, it was bland. There was really no enhancement within it at all. So anecdotally, maybe if you're looking for just whether a lesion is vascular or not, SMI is more sensitive, and in some cases may be able to avoid the need for contrast administration. Of course, I think detection of vascularity in focal liver lesions is dependent on whether there is a background of chronic liver disease. Because if you have a hepatitis or known significant fibrosis, then anything vascular is an HCC until proven otherwise. You have to correlate with the Gray scale as well, but it is in the detection of vascularity in renal lesions, which I think it may be of use, where a solid vascular lesion needs further imaging and needs sampling or excision. So maybe that's an area which needs further research. And then it brings the question to those who are avid contrast users is, can SMI avoid the need for contrast enhancement? Some cases that I've shown you where maybe it has done, but also some cases which show otherwise. Here is a patient, again, with a known malignancy and an area of, looks like focal fatty sparing in a fatty liver. And power Doppler, here again, you really show no vessels, some vessels running through it, but not as convincing as when you turn on SMI. You can see nice vessels flowing through it. Let's look at that again. So really quite structured vessels, and we thought, oh, this is just going to be focal fatty sparing. But of course, we gave contrast, and lo and behold, in the late phase, you can see it's 3 minutes after administering contrast, there is a focal lesion within that area of focal fatty sparing which has washed out, and there's a metastasis sitting in this area of focal fatty sparing. What are the uses, perhaps, of SMI which may be able to replace contrast, perhaps, is there are centers in Europe which utilize microbubbles in children to look at reflux. But here's a patient, and this videos I'm going to show you are courtesy of Dr. Sarah O'Hara from the US, where here is a child with a bladder, and this is a longitudinal image, and this is a dilated lower ureter. Just watch what happens when we turn on SMI, and you can actually see, just with SMI, the reflux of urine back up into the ureter itself, and there's no contrast which has been administered into the bladder itself. Looking at the kidney itself, now you can actually see the blood flow, but look at the reflux of urine back up into the renal itself, and this is without contrast administration itself. So maybe quite a powerful tool now that you have, which may avoid the need for contrast. Of course, there are limitations. You probably saw from the images that you do get a little bit of noise, which you have to separate out, and it is really best to show you the video clips and review the video clips. Echogenic structures in the near field do give you what looks like apparent artifact and signal, and really the real-time clips are essential for assessment. Again, structures which are close to the cardiac or where you get a lot of breathing artifact or movement, you get significant image degradation. But you can also use SMI with contrast as well when that's the case. And this is one example where we found it more useful than the contrast-enhanced ultrasound image. This is a patient, again, with a known malignancy, a hypervascular lesion seen on CT, and we were asked to characterize it further. If you look at this, there's a funny vessel, an area of hyperenhancement with contrast ultrasound. We weren't quite sure what to make of it. It remained hypervascular, and we thought, it looked a bit like a vascular malformation on here and not a solid lesion, but it's very difficult to show you the inflow and outflow of this vascular malformation on this contrast ultrasound image. But when you switch over to the low mechanical index mode using SMI, you can actually see it beautifully highlights the vessels flowing in and out of this vascular malformation with contrast itself. So we were very confident this is a vascular malformation within the liver and not a malignancy or metastasis. So just leading on now to contrast enhanced ultrasound, I'll just draw your guidelines for those of you who do use it or are about to start using it. I know that it's only Definity that is available for use in Australia, but it's as good as what we use in Europe, which is Sonoview. But there are lots of guidelines, particularly this I draw you to from the FSM community and WFM, and these are free to download, and looking at the good practice for ultrasound in the liver and non-hepatic applications. These are all well established. I'm not going to dwell on this, the focal liver and renal lesion characterization, but highlight that pediatrics is very, very useful. It is off-label use, but there have been lots of lectures, and off-label doesn't mean illegal. It means that you just use it cautiously and with agreement with the hospitals and pharmaceuticals. Very useful, and we use it a lot in pediatrics. One thing to say, one improvement with contrast, and it keeps improving, is the use of contrast and single crystal technology. And I'd just like to highlight how good it is. This is using the latest single crystal technology with Toshiba. You can actually see, as I start the clip, a hypoechoic lesion on a background of a fatty liver. And we were asked to characterize this further with contrast ultrasound. And here you go, there's the cursor, and you can see instantly, you know that this is a hemangioma. It demonstrates peripheral nodular enhancement, filling in from the outside centrally. And as we progress into the portal venous and late phases, it fills into near-completion itself. But just look at the pixelation, the homogeneity, and the depth that you can achieve with single crystals. So it does improve your image quality using single crystals. The other emerging application that I just wanted to highlight in my talk today, trust-guided prostate biopsies I allude to, but I'll show you some examples later on in my talk. But it is really sentinel lymph node detection, which I think has an interesting emerging application. And this is particularly the model of patients with breast cancer. So the sentinel node, as you all know, is the first lymph node in the chain affected by metastasis in the breast, and it acts as a very nice model because staging of the disease is performed at surgery, either by administering blue dye or radioactive tracer, and it's removed, and if it's positive, the patient has to come back for an axillary clearance. Well, interestingly, microbubbles are taken up by the lymphatics. And this was shown actually by work by Barry Goldberg's group and Fleming Forsberg's in Philadelphia, where you can see microbubbles in a swine model. This is a pig model with melanoma. And what they showed was these are the lymphatics outlined in the lymph node. And where you have tumor, shows as defects within the lymph node itself, and the normal lymph node takes up the microbubble itself. So interestingly, microbubbles just hitch a ride and get taken up by the lymphatics. And in breast, it is this known pattern of the lymphatic drainage around from the nipple upwards into the axilla, and where the methylene blue and radioactive tracers work is where you inject them, you hope to hitch a ride on the lymphatics and find the sentinel lymph node. Well, we can do that with microbubbles because they get taken up by the lymphatics, and there have been several studies and centers now which are trialing this out by injecting into the skin and using your microbubble software, tracking it up along the lymph node. And I'll be showing you some examples in a second. So you don't have to inject very much, up to 1 ml of microbubbles, ultrasound contrast in a periolar region. But what is crucial is the settings of your transducer and tuned to the microbubbles at that particular frequency. So here's an example of it injecting around the nipple itself, and you have to watch carefully because you get quite a lot of artifact with the breakthrough from the echogenic structures in the breast. But here you go, there you go, there's the lymphatic. It dives, and not only does it dive down deep into the pectoralis, you can see it highlighting a lymph node here. Has a very tortuous course, and when we first started, it actually starts very superficial, and it can be very tortuous. So here's an example of a very tortuous course, again injection into the nipple area, and you can actually see there's the lymphatic flowing, and we're trying to trace it right out. See, double backs on itself, flowing right out again. Can take a while to find the sentinel lymph node, as you can appreciate. And there you go, highlighting in the sentinel lymph node itself. Of course, then now we have a tool which we can actually percutaneously biopsy it. We can actually sample it now. And we prefer to sample, once we've detected it, we prefer to sample it in B mode because we can actually see where our needle is coming in. And you can see in this case, it's actually quite a small node with only some cortical thickening. It's only about 4 or 5 millimeters. It can be quite tricky to actually sample most of the lymph node itself. But what can help is beam, which can angle your beam, and is, again, unique to Toshiba, that you can actually highlight exactly where your needle is. So this is a lymph node, and it's being biopsied. And you can actually see the cutting edge of your needle itself much more clearly if you can use beam. So to date, we have looked at about analyzed 48 patients with follow-up over 20 months, and you can see we had quite a bit of failure. It's a learning curve. You have to optimize your settings, and in a proportion of patients, they won't drain because they've got interrupted lymphatics. But that is also the case for blue dye or radioactive traces. So far today, we've had 37 biopsy-proven cases. These are the tumor types of the cases. And the majority we had were correct, based on they also went to have a sentinel lymph node excision at the same time. 24 true negatives, 5 true positives, 6 false negatives. So i.e. we didn't pick up the cancer, but it was found when they removed the whole node itself. You may say it's not particularly useful then, but perhaps where the thinking is changing with lesions is when we actually analyze what was found in those nodes histologically, they were micrometastases, not macrometastases. So these were lesions, about 1 millimeter of tumor within that lymph node itself, no more than that. And 2 of them only had isolated tumor cells. We didn't understand this. We had 1 false positive where our biopsy came back as some positive nodes in the lymphatics or tumor cells in the lymphatics, but they couldn't actually find any tumor in the lymph node itself. Well, why is that important? And it's important because of this paper by Giuliano published in JAMA, where they found that overtreating by axillary clearance in patients with micrometastases in the lymph node does not prolong survival. So if it's a micrometastases, the trend is not to overtreat with axillary clearance these days, which is overly associated with lymphedema and a lot of morbidity when you clear the axilla. And this is just to quote some statistics from a paper by Ali Seaver's group, who's really done quite a lot of work with this in the UK, and you can see he's had over 300 cases. They detected 17% of his positive lymph nodes that were micrometastases itself. So perhaps it's an issue of a sampling issue rather than a histological issue, and there are some groups now trying to remove the whole lymph node by vacuum excision or percutaneously. So areas of research currently in some centers at the moment. Just out of interest, if you took micrometastases out, like we don't want to find them because it doesn't change what you do with them, then actually in our small subset, then we actually have no false negatives because we didn't want to pick up the micrometastases in the first place. But a lot of it is still work in progress. It's certainly one thing, it's feasible, and it can potentially save patients an additional operation. And that's also thus associated with cost and morbidity. One key thing that we found was the optimization of your probe, and that took us a while to get the settings correct to actually see these microbubbles. And at the moment, there are multi-center trials going on in the UK looking to validate this technique and its clinical impact. Which then leads me on to some other new technology, which really isn't so new. It has been around for a little while, but keeps improving, and that is fusion. Well established in interventionalists who use it as for ablation techniques, and one of the latest developments are needle guides to tell you exactly where the needle tip is after you've ablated, and this can be particularly useful. Here's an example loaned to me by Professor Ganji in Strasbourg. Here is a CT fused image of a lesion, and here's the ultrasound image, and you can see it's white, it's got gas. He's already had some treatment to this lesion, and they were ablating it. And here is the needle guide. It actually tells you exactly where your needle tip is going to be once you've positioned it. And you can appreciate on ultrasound, you may have difficulty because of the echogenicity within the lesion itself, knowing exactly where the tip is. So very useful for the interventional radiologists who utilize this. But as a diagnostician, perhaps how can it help me as a diagnostician in day-to-day practice? Well, here's some examples of where we found it useful in focal liver or kidney characterization. In the majority of cases, we get a lot of cases where we find an indeterminate lesion on CT. Can you see what it is on ultrasound? And we find it in most cases, except for those very small lesions, those 2 or 3 millimeter lesions, which find difficulty seeing what is it, may need to go to further investigation. Well, here's an example of a patient with a known malignancy and an indeterminate CT lesion. But if you actually look at this video clip, you can actually see it fuses nicely with this simple cyst here. So it's just a cyst, easy to find and to be absolutely sure you are on that same lesion. It's only 5 millimeters in size. And this is where it's perhaps you might have missed it if you didn't have fusion. In a patient you can see with some dilated intrahepatic ducts and a known cholangiocarcinoma. What is this hypodense lesion? Well, if you look closely at this video clip again, it's a very, very small cyst in the same area there compared to the density. So you can be absolutely sure that that's what you were looking at correlates with the CT, and it's a cyst. You don't need to do anything further. Sometimes they can be difficult to see, and in this case, we actually couldn't see it on B mode and had to administer contrast, and when we did that, we found that this was just a cyst in a hypodense density within the CT scan on the liver itself. Of course, it can work both ways. So here's, again, known malignancy. What's this indeterminate lesion? When you actually see it on B mode, it's an echogenic lesion. And when you look at the contrast image itself on CT, you can actually appreciate some peripheral nodularity. And this is clearly, with the two in combination, we're confident that it's a hemangioma. With the kidney, here's a hyperdense cyst on the edge. And when you actually fuse it, it looks a bit more solid than cystic. And of course, with ultrasound, you have the advantage of giving contrast. And here it is, the fused image, giving contrast, and you can actually see it appears bland. So this was just a simple renal cyst and a hyperdense cyst seen on CT with proteinaceous material. One area where it's proving to be useful at fusing is with MRI scan and the prostate. And here you can see the prostate MRI scan and dynamic enhancement with contrast, a slightly more hypervascular area within the prostate. And there's some studies now coming through showing that targeted biopsies to that hypervascular area with fusion actually aids your pickup of prostate cancer, where previously patients may have had negative biopsies, although an elevated PSA. So prostate fusion certainly shown to be very, very helpful. So clinical impact with fusion really, as a diagnostician, it does help with your diagnostic confidence and can avoid the need for further imaging, and certainly helps very much with targeted biopsies and treatment. So turning on to the last sort of state-of-the-art technology in elastography, which is quite a hot topic at the moment. I just draw, there are plenty of guidelines, and this is the FSM guidelines, together with WUFM, published not so long ago, and these are again free to download, looking at the basic principles in technology and their clinical applications. two types of elastography: strain, which has been around for a long time, and shear wave is the latest technologies looking at the elastic properties of tissue. Really quite a few applications if you look at the literature, but I'm going to just concentrate on the liver and looking at it staging liver fibrosis. So we all know about strain, and it's just a manual compression, decompression, and we're looking at tissue movement based on Doppler imaging or a kernel-based methodology. However, with shear wave, we're actually inducing a pulse either as a mechanical impulse, like in FibroScan or transient elastography, or really with imaging now in the ultrasound systems using a high radiation force-induced energy ultrasound beam to distort the tissues. And what happens is, with that high ultrasound wave, you distort the tissues, it produces shear waves or ripples of waves, and it is the measurement of the speeds of the shear waves that indirectly denotes the elastic properties of that particular organ or tissue that you are sampling. So really, it started off with FibroScan, and then really Siemens came on with their VTQ, visual touch quantification, and Toshiba now has shear wave elastography, and so do some of the other manufacturers, and some have advanced properties compared to these earlier forms of shear wave elastography. I only put down liver lesion characterization in terms of research because there are some groups with looking at to characterize liver lesions, but really contrast ultrasound still really is the key to liver lesion characterization. For those of you who've not seen FibroScan before, it really is just a mechanical transducer inducing a mechanical pulse and then giving you a measurement of the pulse shooting through the liver, what we think is liver because you have no imaging, and giving you a stiffness measurement here in kilopascals. And most of the data has come from FibroScan because it's been around the longest, and really it's got a high negative predictive value is what most papers are saying, that if a kilopascal of 7.6, you can be pretty certain that there is no significant fibrosis, and if it's more than 12.5 kilopascals, you can be certain that there is significant fibrosis or cirrhosis. One key disadvantage is it's got no imaging, so you don't know what you're transmitting or what you're measuring through there. And there is now where ultrasound imaging and the scanners come into play and have shown to be much more beneficial. Here is an example of Siemens and the RFE technique, and this is just point measurement. So you have region of interest, it sends a pulse down and it gives you a speed measurement and your depth. So you can actually be sure that you're actually measuring in the liver, and there are no focal lesions within it, and you're not on the gallbladder or a big vessel. And some of the latest meta-analysis of 13 studies show that you get a better success rate with RFE compared to transient elastography, and the sensitivity and specificities when there's more significant fibrosis is quite similar, and this is a meta-analysis published not so long ago of over 1,000 patients. But with the Toshiba shear wave, there is one added advantage now, so things are getting better. Here is an example of what you see. You actually, this is a patient with cirrhosis. You can see irregular liver edge subcapsular ascites. When you turn on shear wave, you have your region of interest, which can be as big as you like, but you get a color map as well. So it's not point shear wave, but also a color map in meters per second or kilopascals. But one thing which really just separates out Toshiba's shear wave elastography is that you have a propagation map. And the map next to this tells you how well or how reliable or good your shear wave propagation is. You can see that it has to be parallel lines for it to denote a good shear wave propagation, and where it's distorted, it's where it's around vessels. And that helps you measure, because you don't want to be measuring around the vessels because you will get some variation and inaccuracies if you do that. You also have it in continuous mode, and you can see it. You take several waves, several pulses through, and when you're happy with it, you have one shot, and you can see how nice your propagation is here, and you can be pretty certain you're getting a good assessment of the liver there. You can take as many measurements as you like. You're not confined to just one point measurement. You can take several regions of interest. And you can get your measurements in meters per second or kilopascals itself. Well, how do you interpret it? Well, because it's quite new technology, then there isn't as much data as with transient elastography or RFE. And this is a white paper by Dr. Ijima's group in Japan, and she looked at a whole variety of chronic liver disease, and you can see there's an increase of the shear wave speeds with significant fibrosis. It's the Matavir scoring system. But it is the cutoff value of 2.2 which separates out really F4, significant fibrosis and cirrhosis, from the rest of the fibrotic groups. But having said all that, the numbers so far are small. There are clinicians don't have a problem at diagnosing cirrhosis, and it is the separation of the intermediate groups, the F1s to F3s, that have proven challenging. And that's not only for the shear wave, Toshiba shear wave elastography as a whole, across any of the manufacturers. You'll find that perhaps that the shear wave speeds are different from manufacturer to manufacturer. You can see the cutoffs, for example, for RFE in significant fibrosis is 1.8. Toshiba's and supersonics are slightly higher. So at present, until there are, what you need are some local reference charts. If you're going to use it locally in your hospital, you have to derive your own reference charts for the moment. And there are multi-center studies on the way to provide reference charts for the Toshiba group as a whole, but you can't interchange them between scanners. And this is also shown, and in my next several slides, this is how Toshiba compares to the other systems, Toshiba versus RFE and transient elastography. Its speeds really approximate best to the supersonic system. And you can see actually supersonic also has a elastography map denoted very similar to the shear wave with Toshiba. So the trend is not to just have point elastography, but a map with it as well. This is a latest paper by Anthony Samir's group at MGH, looking at a whole variety of chronic liver disease. And you can see separation, but again, overlap in the mild to moderate fibrosis group. But certainly, the extremes are good. But it gets better if you can separate out the disease entity on its own. So if you know what disease process is, the separation gets better if you just take hepatitis C on its own or hepatitis B on its own, or alcoholic liver disease. As I alluded to, different manufacturers give you slightly different speeds. And this was borne out in a study performed by KIBA, which is the Quantitative Imaging Biomarker Alliance at RSNA. And this poster, which at this stage where it was performed, there were only these systems which were available for shear wave elastography. That's the transient elastography, the Philips, and the RFE and supersonic. These Verisonics were actually the homemade physicists derived, so they know the exact parameters they were using, and the Phantom with a known elastic property and speed. You can see there's a huge variation between the manufacturers itself, and this is based on a Phantom, soft Phantom. Interestingly, if you use a stiff Phantom, some of them overmeasure, and where they were previously undermeasuring, and therefore, at the moment, they're trying to address the issue of why there are this slight variation between the manufacturers. Well, let me muddy the waters a little bit more with liver fibrosis, because there are other causes of liver stiffness other than fibrosis. So we know that liver stiffness can be affected by increased venous pressures with right heart failure, or if there's active inflammation and edema within the liver or other deposits. So not just fibrosis gives you a stiff liver. So how can we use this or interpret this clinically? Well, if you did fibroscan, you have to know what sort of disease process your patient has to actually use what score you have. And you can see this chart that they give you has got quite a lot of overlap depending on, particularly in the middle group, depending on what disease type it has. And again, if you're reporting to hepatologists, they'll be used to getting the value in kilopascals. But really, kilopascals is a conversion of what you're actually measuring, which is the speed in meters per second. It's an equation. And this is just a study by Dr. Spurrier's group, where he looked at this RFE compared to FibroScan itself. And what he did with the FibroScan was he converted it back into the meters per second based on the equation. And you can see, again, just highlighting that the speeds are different from transient elastography to RFE, denoting this, fibrosis itself. But nonetheless, having said all these complications, elastography as a biomarker does better than the serum markers of fibrosis that we use, or our clinicians use. And this is our own data, looking at RFE, transient elastography, and then the serum markers, which are these three groups here, FIB4, AST-ALT ratios, and a prescore, which are all markers and measurements that are performed. And you can see the area under the curve of RFE and transient elastography is better. RFE tends to do better with the lowest of mild to moderate fibrosis compared with the transient elastography. And when you get to the more significant fibrosis, the F4s and F3s, then they tend to be a bit more similar. So, bearing that in mind, is shear wave elastography ready to be used as an addition to routine ultrasound liver assessment in patients with chronic liver disease? It can be useful because it has the extremes are good. It's got a high negative predictive value. And if you can avoid a liver biopsy, then it certainly saves on costs, but also morbidity, where there is a 1 in 10,000 chance of death in patients who undergo a liver biopsy. There are current algorithms of how to use transient elastography or shear wave elastography, but these are really based on FibroScan because it's the largest data set. So I alluded to normal or extremes are reliable. The center group is difficult, but that goes across elastography as a whole. And I just borrowed this chart from Christoph Dietrich and his European course book, really just highlighting that these areas are reliable. The equivocal zone is the mild to moderate fibrosis. And just to highlight that we actually have some guidelines in the UK by NICE, National Institute of Clinical Excellence. This is a busy chart, but really just to take home that they separate out into disease processes. This is hepatitis B. And you can see where it's in that middle range, it says degree of fibrosis cannot be accurately predicted in this range, and you have to go clinically and still biopsy. There are charts for hepatitis C, but what is helpful is that it can avoid the need, perhaps, for those early fibrosis for a liver biopsy, and it can be used as a serial marker to see how significant your liver disease is progressing, perhaps where it doesn't matter so much that the patient is their own control. So there are many unresolved issues still with shear wave elastography at liver fibrosis, but it could be a very significant tool. First of all, different manufacturers have different values, and Kiba is working on that, and what is normal? So I think that reference charts from manufacturers are key. FibroScan gives a measurement in kilopascals, and that is what our clinicians are used to looking at. But really, the purists, the physicists say you should be quoting in meters per second because that's what you're measuring. And we do get some failure rates in large patients because your shear wave doesn't propagate properly after 5 centimeters depth or more. And in some of our patients in the UK, by the time you get to the liver, you're already at 4 or 5 centimeters. So it's not perfect, but certainly a helpful tool. So with that, is imaging the previously undetected, is it useful? Well, really the key feature here, SMI, really very useful. It allows imaging of the microvasculature and lymphatics ultrasonically, which have potential applications, I think, hopefully I've convinced you, of significant clinical value. Fusion, as a diagnostician, it can help with diagnostic confidence at detection and characterization of those small, subtle lesions that you pick up on CT or MRI, which you need to characterize further, and certainly very helpful in treatment and targeting of biopsies. Hot topic, shear wave elastography really has huge clinical potential at staging fibrosis in clinically in chronic liver disease, although currently there's still several unresolved issues which need to be sorted out in the community as a whole. So with that, I'd just like to thank some of my colleagues who've loaned me some slides in Europe, and also Toshiba in UK and in Japan.